I'd like to welcome you to this discussion of the neurosurgical management of abusive head trauma. I'm Dr. Jonathan Martin with Connecticut Children's and the University of Connecticut School of Medicine. I have no disclosures. I would like to acknowledge Dr. Nina Livingston, a child abuse pediatrician at our institution, who helped with assembling this presentation. Abusive head trauma, or AHT for short, has been defined as an injury to the skull or intracranial contents of an infant or young child due to inflicted blunt impact and/or violent shaking. Given its precision, abusive head trauma is preferred over terms such as battered child syndrome, shaken baby syndrome, and non-accidental trauma. Injury mechanisms for AHT can be generally characterized as contact, inertial, or a combination of both. Contact injuries involve the focal application of force to the infant's head with resultant injury at or adjacent to that point. Examples of such injuries include skull fractures and epidural hematoma. In contrast, inertial injuries involve the application of rotational forces to the infant's head. Shaking is the classic example of this. The periodic directional changes result in contact of the brain with the inner surface of the skull. Inertial injuries may be paired with contact injuries to magnify forces applied to the brain, resulting in more significant injuries. Examples of resulting injuries include subdural hemorrhage from injury to bridging veins, parenchymal injuries, and ischemic injuries such as those seen here. Abusive head trauma is the third leading cause of head injury under the age of 5 and the leading cause of severe closed head injury in infancy. AHT has an incidence of approximately 30 per 100,000 for children under the age of 1, with its peak incidence closely approximated to the curve for peak infant crying. It's important to remember that in most circumstances, the evaluation of the infant with suspected abusive head trauma is a team sport. The neurosurgeon is a member of a team that ideally consists of a child abuse pediatrician, pediatric surgeon, subspecialty consultants to include ophthalmology, hematology, and orthopedics, as well as social workers, law enforcement, and others. Awareness of resources such as the ACS Best Practice Guidelines for Child Abuse and local requirements for reporting suspected abuse are essential for all providers involved in the care of children. The majority of children diagnosed with AHT present with either no history of trauma or a history of trauma that evolves or changes over time. It is not uncommon for the history to be incompatible with the developmental capabilities of the child, for example, a 1-month-old rolling off a changing table. Delays in seeking medical care are also common in these patients. As child abuse is often repetitive rather than an isolated single event, multiple visits prior to diagnosis are unfortunately common. Signs and symptoms are highly variable in abusive head trauma, as children may present both following an acute abusive event or as a result of sequela from a prior abusive episode. Children with acute injuries can present with severe neurologic impairment to include apnea, seizures, and hypotonia. Victims of AHT frequently have bruising to the torso, ears, and neck. In contrast, children with remote prior injury may present with a normal neurologic exam and no external evidence of acute injury. Presentation may include macrocephaly, developmental delay, vomiting, or irritability. Unfortunately, many symptoms present in the victims of abusive head trauma are vague and overlap with symptoms commonly seen on routine health visits in infancy. Physical exam findings relevant to the neurosurgeon include macrocephaly, fullness of the anterior fontanelle, sutural diastasis, and sundowning. Review of head circumference data may reveal an abrupt upward transition point in head circumference velocity that can indicate timing of a prior injury. Alterations in wakefulness, tone, and motor exam may be present. More ominously, seizure activity may be present. Additional physical exam findings frequently present include bruising, often on the torso, head, and neck, retinal hemorrhages. Most commonly, these are bilateral, multi-layer, extending from pole to pole, but they can be unilateral and limited, and skeletal fractures, both subtle, like this metaphyseal corner fracture, or more obvious, such as these healing posterior rib fractures. Pediatric radiologists are trained to identify these patterns of injury. Note, no one grouping or pairing of injuries is required to establish a diagnosis of AHT. The initial evaluation of a patient with suspected abusive head trauma proceeds in line with established advanced trauma life support protocols. ABCDE should be a familiar mantra for this neurosurgical audience. Imaging should include an initial non-contrast head CT to be followed by a skeletal survey and non-contrast MRI. Ophthalmologic evaluation should be accomplished as soon as practical, as intraretinal hemorrhages can resolve within 24 hours in some circumstances. Communication between ophthalmology and neurosurgery is essential, as the use of dilating drops can impact on neurologic assessment during the critical early phase of patient management. Child abuse pediatricians play a critical role in collecting history and considering a broad differential diagnosis in these patients. Several imaging modalities can be used in the evaluation of abusive head trauma. Ultrasound is an excellent screening tool, but is hampered by poor visualization of bone and limited incination windows for hemispheric and posterior fossa pathology. As in adults, CT is the workhorse for evaluating the traumatic patient. Concerns for radiation exposure are more acute in the pediatric population. MRI provides increased resolution and sequences that provide additional detail regarding fluid composition, ischemic, and chronic injuries. However, patient access and transport risks limit the utility of MRI in acutely injured patients. The neurosurgeon is often tasked with providing guidance regarding the safety of pursuing imaging studies that can provide important forensic information to the case. A neurosurgical audience is familiar with a broad palette of imaging findings present in closed head injury. Subdural hemorrhage is the most common finding on cranial imaging of children with proven AHT, seen in up to 68% of cases. Subdural hemorrhage on CT may be high or low attenuation. Hemorrhage is commonly interhemispheric with extension over the convexities, or posterior fossa in location. Prior research comparing radiographic characteristics for both AHT and accidental injuries in children has defined the presence of subdural hemorrhage and ischemic injury as strongly favoring abusive head trauma. This same work suggests that epidural hemorrhage is more commonly seen in accidental injury. In addition to guiding treatment, imaging findings can provide forensic support for a diagnosis of AHT. Examples include hemosiderin deposition from prior gliding contusions seen on susceptibility sequences, spinal imaging findings to include subdural fluid collections such as those illustrated here with near total effacement of the subarachnoid space adjacent to the cauda equina. One of the most specific imaging findings for abusive head trauma is the tadpole sign, or hemorrhage associated with a bridging vein from the cortex to the superior sagittal sinus. It's worth mentioning the work that is being done to explore new means of diagnosis in this population. Evolving work with MRI sequences has created black bone sequences that approach the efficacy of CT in the detection of fractures, with other tweaks that have improved detection of acute blood. This work will result in reduced radiation exposure in this vulnerable population. Equally, if not more exciting, work to develop useful biomarkers could radically shift patient screening and reduce the incidence of missed injuries. The importance of maintaining a broad differential diagnosis in suspected AHT cannot be overstated. The evaluating team must consider presenting history, family history, and review of systems, entities to include accidental injury, benign enlargement of the subarachnoid space, and birth-related intracranial hemorrhage, and medical and genetic mimics to include coagulation disorders should be considered. There are outstanding policy and consensus statements available on this topic that are available, which I strongly recommend to this audience. Several clinical decision-making tools have been developed to assist with risk stratification of patients in environments ranging from the outpatient and ED setting to the pediatric intensive care unit. CDM tools are derived from original research and incorporate 3 or more variables from history, physical exam, or simple tests to guide patient management. Basic familiarity with these tools can be helpful. 2 observations regarding these tools. First, bruising of the torso, ears, and neck figure prominently in all of the major CDMs for AHT. Second, it is noteworthy that neurologic findings, other than apnea and seizures, are conspicuously absent from these tools. While speculative, I believe this speaks to challenges with the neurologic assessment of. An in-depth discussion of the initial management of suspected AHT is beyond the scope of this brief talk, but aligns largely with the content from the 3rd edition of Guidelines for the Management of Pediatric Severe Traumatic Brain Injury. 2 caveats to this in the infant population. 1, there is data to suggest that ICP monitoring is less commonly employed in the infant population. And 2, seizures are far more prevalent in the AHT population than in the general population of pediatric closed head injuries. Seizure prophylaxis and EEG monitoring should be strongly considered in any patient with suspected AHT requiring ICU-level care. When considering surgical management, it is important to acknowledge that there are no established standards of care for treatment of these patients. For acute injuries, treatment often mirrors that of adult acute injuries, with some age-specific wrinkles. Surgical management of non-acute subdural collections resulting from abusive head trauma range widely based on individual preferences. Institutional case series may provide the best view of treatment options. Recognizing the limitation of these series, they do provide the reader with individual perspectives that consider the options in the context of minimizing anesthetic exposure, improving visualization of the subdural space to maximize clearance, and avoidance of permanent shunt hardware. Regarding the treatment of non-acute subdural hemorrhage, Milo and co-authors presented their 5-year experience managing non-acute subdural collections in infants and toddlers. They reported decreasing requirements for subsequent interventions and reduced infection risk with increasingly invasive treatment options. Their favored management strategy was subdural peritoneal shunt placement with an acknowledged complication rate of 26%. In another series, Bruce Kaufman's group in Wisconsin presented their experience using a small osteoplastic craniotomy to improve visualization of the subdural space. Outcomes were comparable to conventional burr hole drainage, which was performed by some members of their group. The authors reported reduced need for repeat intervention, as well as fewer subsequent procedures for failed cases in patients undergoing mini craniotomy. In the setting of acute injuries requiring craniotomy for decompression, I would highlight 2 key outcomes of note in this patient population. First, children with AHT have worse outcomes than accidental injuries. In one series, children with abusive head trauma had a 12-fold increase in the odds of death and 3-fold increase in worsened outcome compared to children with accidental mechanism of closed head injury. Second, young children undergoing decompressive craniectomy have a high rate of bone resorption, approaching 100%. Looking more generally at outcomes, even with the best provision of care, mortality for victims of abusive head trauma remains high at up to 20%. Among survivors, 2/3 are left with moderate to severe deficits. Of critical importance, as many as 30% of children with AHT are misdiagnosed at their initial medical presentation. Factors leading to increased risk of misdiagnosis include Caucasian race, married parents, young patient age, and the absence of seizures or respiratory compromise. Children with missed injuries have a re-injury rate that is estimated at 25%, with a 7% risk of mortality. These numbers speak to the importance of recognition and treatment of this entity by neurosurgeons involved in their care. Before leaving this topic, a few comments regarding medical legal aspects of abusive head trauma. AHT cases by their nature often arrive in the judicial system. In most cases, neurosurgeons are involved as fact witnesses to represent the care they personally provided to the patient. If served with a subpoena, You should review the document with your facility's risk management department and discuss your roles and responsibilities in the case. Once your role as a fact witness is confirmed, remember that your testimony is not to defend your care. It is germane to decisions regarding where a child will reside or whether someone will be found guilty of committing a crime. A few parting tips. During care, document and describe what you see. Fluid analysis is always helpful. Exclusion of inflammation, infection, and neoplasia with objective results is helpful both clinically and in court. Maintain a differential diagnosis in your thought process and documentation. Stick to the facts and don't speculate. And finally, if you have one at your facility, get to know your child abuse pediatrician. A healthy relationship with this individual can keep you out of court and in your operating room and clinic. Thank you very much for your attention.